So the idea for today's presentation is that it's helpful once in a while to try and string together everything we've learned and put it in the context of how are we going to apply it at the bedside. And so these cases are all focused on lung ultrasound because we've, in the past, Eric has done some cases on cardiac ultrasound, and we talked about some volume responsiveness. So this is mostly focused on lung ultrasound. I acknowledge that for this year, we haven't quite done the lung lectures yet. So I'll try to point out to pathology, but it wouldn't be everything that we're going to hear in the next 1 or 2 lectures about lung ultrasound. So if you have questions about something, or if you have questions about one of the artifacts or findings, please stop me and let me know. And so the way that I think about lung ultrasound in the context of pediatric critical care is how I've broken down this presentation. I think the most useful that this is for me outside of figuring out if somebody has a pleural effusion is to help in undifferentiated respiratory failure. And so when you have a patient who presents to you with respiratory failure and you're trying to understand a little bit more about their pathology, especially in cases where there may be overlapping features, that's where I find that pretty helpful, and I find a systematic approach quite helpful. And the other ones are the ones that are quite basic and are also fit within that systematic approach. And so those other things would be pneumothorax, pleural effusion, and thinking about and differentiating between consolidation and atelectasis. So with that, let's dive in and think through some of these. Because these are all cases, so I've tried to put in clinical vignettes from our own patient, and all of the images are taken by fellows at our program or attendings, and some of them are my own. So huge shout out to all of the fellows who helped in taking these interesting cases and pictures. So the first one is a 6-year-old female with history of traumatic brain injury as an infant. Additional things include obstructive sleep apnea with non-invasive ventilator at night, who presents to the ED with new onset of hypothermia, increased work of breathing, and worsening oxygen requirement. On examination, the patient's breath sounds are diminished on the right lung diffusely and left lung bass. Coarse and fine crackles are heard in multiple areas of the chest. And then the ED provider goes on and obtains some lung images. So the images are broken down by the right and the left lung. And so this first set of images are those from the right lung. Generally, in our institution, we use the 8-zone way of systematically evaluating lung. So going through the 1R and 2R are the right anterior chest images, and then 3R and 4R are the lateral, and then similar for left ultrasound images. So going through the images, the first one, it shows that there is, you see a well-defined pleura, there is some pleural sliding, there are some A lines here. Towards the left of this image, in the lung preset, you can see some small amount of subpleural consolidation, maybe some air bronchograms here. In the second clip here, again, this one is much more pronounced in terms of finding, where you can see a pretty decent size subpleural consolidation with air bronchograms in the center. There are a bunch of confluent B lines that come from that. And then the edges of this, they look pretty sharp, rackety, which sometimes what we describe as the shred sign. And on the lateral images, again, you see some confluent B lines, some air bronchograms. And then let's see if this will play. And then sort of similar findings on the right lateral as well, where you're now starting to see the kidney and the liver over here, and then some confluent B lines, maybe some small subpleural consolidations. Moving over to the left side. So in this first image, you see there are some B lines The pleura still looks pretty nice and smooth. I don't see anything else. And then lower anterior lung zone, you start to see this subpleural consolidation right here in the center of the screen. There are some V lines that are confluent from here. Those findings become much more pronounced when you're approaching lung from a lateral field. And so here you see a ton of these air bronchograms, which are hyperechoic areas with some V lines emerging from them, pretty large in size, almost, I want to say, about 3 to 4 centimeters wide. Similar findings on the lateral lung, right? So having seen all of the pictures that we've seen in the right and the left lung zone, let's then think through how could we systematically approach it. So the first thing that I think about is when I'm examining these patients is looking at pleural sliding. Whether the pleural sliding is present or absent. In this case, the pleural sliding was present in all of the lung zones. So we can safely eliminate out all of these findings right here, which would have included pneumothorax and in certain rare cases, pneumonia. So then we go down the path of pleural sliding present, and then do you predominantly see B lines or do you predominantly see A lines? And as we noticed that there was just the right anterior zone, which had a few A lines, but for the rest of the lung exam, there were predominantly B lines that were present. So I'm going to eliminate out this part of the systematic approach, which would get rid of disease processes like asthma, COPD, pulmonary embolism. And then with the B lines, further thinking about were B lines present in all lung zones and were they symmetrical in nature? They weren't, and they were a more diffuse and confluent pattern. Were B lines present in some lung zones with irregular pleura? Or were there B lines, abnormal pleura, and a ton of air bronchograms and some other findings? Which that seems to be what was the most consistent with our patient. So that leads us down the path of a patient who has pleural sliding, predominant B lines, along with abnormal pleura, air bronchograms, and other findings that are consistent with pneumonia. So that would be what would be the diagnosis for this patient. There was a study that was published a couple of years back, trying to look between pneumonia and atelectasis. And I wanted to spend a few minutes just talking about this, since that's been one of the questions that comes up quite commonly, especially as people get facile with lung ultrasound and start to pick up on these air bronchograms and consolidation. And so in this study, they had about 120 adult patients, and they broke down the patients by presence of either static or dynamic air bronchograms. The patients who had dynamic air bronchograms, for the most part, were diagnosed with as having pneumonia, and the diagnosis was eventually based on the physician's clinical impression, use of chest X-ray, use of BAL samples or sputum samples when available. When patients had static air bronchogram, they did an additional thing where they used vascular Doppler to see if flow was present or absent. When flow was absent in those cases, most of those patients were diagnosed as having atelectasis with an overall diagnostic accuracy of 86%. And when the flow was present, it was a little bit still harder to decide what was atelectasis and what was pneumonia. So that's another approach that is helpful to differentiate between the two. Of course, we never think about making diagnoses based on just ultrasound findings alone, and you have a ton of other data points to support your findings. But this is something that's available out there. I haven't had much of experience doing this, and so would in chat comments would love to hear if somebody is practicing differentiating between atelectasis and pneumonia this way. This was the patient's chest X-ray that was corresponding to the time that lung ultrasound was done. So I think it's pretty consistent with what we saw in terms of our lung ultrasound. So moving on, the patient has some initial improvement in examination with escalation of their respiratory support. They were already, remember, on non-invasive ventilation. That was escalated and antibiotics were initiated. However, 48 hours later, the patient has increase in their oxygen requirement. There's no improvement with suctioning, chest physiotherapy, etc. The PICU team, which is where the patient is now, goes on and obtains a lung ultrasound. And so same patient, similar series of images here. And we start to see that in the anterior lung field, maybe there is a small area where the pleura is a little abnormal. You still see these confluent B lines right here as well. But there seems to be at least some degree of resolution of the pneumonia and air bronchograms that we were seeing previously. Those are not as apparent anymore in the anterior lung fields. And then if you look at the lateral lung fields, there is this anechoic fluid collection in between the pleura, which is consistent with pleural effusion on this side. There are also much more prominent B lines, and you see some air bronchograms underneath. So there's still a significant amount of disease burden, at least from when you look at the lungs from a lateral approach. And then moving on to the left side, and the images look a little bit different in quality because the preset has been switched from lung preset to abdominal preset. So these look a little bit more smooth and less grainy than our lung ultrasound preset images. But nonetheless, you can also, in almost all zones here, you can see that there is this anechoic fluid collection, which is consistent with having pleural effusion. So the patient that presented on day 0 had a pneumonia, and then after about 2 days, there is some resolution of pneumonia based on the images, but there is development of pleural effusion. So this is what the X-ray shows, which is quite consistent again with our examination findings from lung ultrasound. The patient is diagnosed with a moderate-sized pleural effusion, and the decision is made to manage the effusion conservatively. The patient's respiratory support is increased. The patient is stabilized. They're given some diuretics to try and improve their overall fluid status. With those measures, the patient does improve slowly with conservative management, is on stable respiratory support, is although a little gradual and slow to wean off their support due to their underlying chronic respiratory disease. The following morning, the patient becomes tachypnic with increased work of breathing. The patient's overall gas exchange is good. The saturation's in the high 90s on 50% FiO2, which is stable. And the patient's venous CO2 is in the 40s, which is similar to, but slightly lower than what had been on the gases previously. Once again, the attending physician grabs the ultrasound and obtains these images. So here, in this case, the images are only from the left lung. And for this first one, you see, here's a linear probe. You see some subcutaneous tissue, muscle belly, but then everything starts to look suddenly a lot more clearer. The resolution is much better because of the linear probe, and we can see that there is this nice smooth pleura with underlying A lines. I don't see any of the vertical artifacts that we were seeing in this previous patient's lungs. And to me, at least, there is no clear lung sliding. I can see what's described as lung pulse, but there's no clear sliding. When we look at the second clip, again, you can see the pleura looks nice and smooth. There's no apparent sliding. Your A lines, multiple A lines can be seen underneath, and there are no vertical artifacts again. In the lateral lung zones, very similar findings to what we see in the anterior lung zone. Again, no pleural sliding and no vertical artifacts. So the way that I would approach this is that I know I have a patient who has a significant amount of disease burden. They had a ton of vertical artifacts in form of B lines, air bronchograms, and all of a sudden I see none of them. I see no pleural sliding. And when I put those two things together, I would be very concerned that the patient has a pneumothorax in that region. And so the point of care question in my mind, based on those images, would have been, does this patient have a pneumothorax? And I think based on those images, I feel very comfortable saying that. And so this was the chest X-ray that was obtained after we got the ultrasound images, which showed a pretty large size pneumothorax, which would explain why the pleural sliding was absent in both anterior and lateral lung zones. A pigtail catheter was subsequently placed, and that caused pretty quick resolution of that pneumothorax. So I like this particular case for multiple different reasons, because it helped us understand the disease pathology when the patient changed. It helped us with reassessment and seeing how the patient's lung pathology has changed and how we needed to act differently to manage the same patient. And then there was a big drastic change in the patient, and we were able to do the intervention based on our findings. So overall, very interesting case. Moving on to some of our other cases, which are much more simpler, one sort of finding, one caveat kind of cases. We have a 2-year-old male who's admitted with pneumonia 48 hours ago, intubated 24 hours ago for progressive lung disease. He had a severe coughing episode followed by an acute desaturation to the mid-70s, despite some simple bedside interventions. The patient is not improving. Portable X-ray is not available right away, so you go ahead and grab your ultrasound. And as I start approaching some of these case scenarios or some specific questions, I always approach the bedside with, what are my point of care questions? Because for the most part, we're not doing comprehensive exams. These exams are limited in what we are assessing. So having a specific question is often helpful in mind. So based on the clinical vignette, the questions in my mind are, does the patient have a pneumothorax? And is the endotracheal tube displaced, or is the endotracheal tube displaced? This is the patient's right lung. And again, we can pretty clearly see the pleura right here. There are some A lines, but this time, in contrast to what we've seen in these previous images, I can see vertical artifacts. And I know that for me to see vertical artifacts, the pleura must slide on each other. So that makes me very comfortable with that. Yes, there is lung sliding on that side. And then on the left side, I don't see much of lung sliding, and I don't see any of the artifacts. So this would make me very suspicious that this patient has pneumothorax. After the ultrasound, the patient continues to desaturate. Would you feel confident in placing a left-sided chest tube? I would, but I would do a little bit more thorough exam and try to figure out how big the pneumothorax is before I go ahead and place the chest tube. Of course, if it's a rapidly crashing patient, then we have to approach that with a little bit more urgency versus if we had some time. The next case is a code was called for an intubated infant who was desaturated to the 60s following repositioning in the bed. The nurse mentions that the patient coughed and then started to desaturate. With manual ventilation, the patient's saturations improved, but only to the mid-80s with a clear end-tidal CO2 tracing. And so you decide to evaluate with ultrasound. And the point of care questions in this case are very similar to the case before. Hey, is the ET tube completely dislodged? With an end-tidal tracing, it seems it's unlikely. Is the ET tube displaced into one of the main stems, or does this patient have a pneumothorax? And so here are some images here. This is the left lung. And on the left side, you can see that the pleural sliding is not great. You can see some A lines, but then I do see some vertical artifacts. And when I see these vertical artifacts, either Z lines or B lines, that would make me less suspicious for it being a pneumothorax, unless I was seeing a lung point, which would be a transition zone between area of sliding or no sliding. And then on the right side, your sliding seems to be perfectly normal, and you have A lines and Z lines. And so the ET tube was diagnosed to be in the right main stem. It was pulled back, and with recruitment maneuvers, there were improvement in patient saturation, and the patient got better. So some of the takeaway here from pneumothorax is that lung point is often considered diagnostic. Generally, with ultrasound, we tend to rule things out, but lung point is one of those rare things where if you see that, you could be pretty comfortable ruling things in. A lines are generally present when there is a pneumothorax. B and Z lines are absent. Absence of lung sliding is not pneumothorax, and other etiologies can rarely cause absent lung sliding, such as a dense pneumonia, pulmonary contusion. And so in those cases, you have to be very cautious when you interpret a patient with pneumothorax. Next case is that of a 3-year-old boy with sickle cell, initially admitted to the floor with URI symptoms, pain crisis. On hospital day 2, he develops respiratory failure and acute chest and is transferred to the PICU. The patient is started on BiPAP, antibiotics are brought in, pain control is improved, and is provided a blood transfusion with some improvement. Over the next 24 hours, his respiratory failure worsens, requiring intubation. So in assessment of this patient, there are several different questions. Does this patient have a pneumothorax that has caused rapid progression? Does this patient have pleural effusion? Does this patient have cardiac dysfunction that is now contributing in addition to pulmonary dysfunction? Or does this patient have evidence of fluid overload or pulmonary edema? So here are some images from the patient. This first one is from the right lower quadrant. Here we can appreciate the liver, diaphragm, and a large anechoic collection, which is a simple pleural effusion. And then floating within this effusion is a pretty dense collapsed lung on this right side. Here's the image on the left side. You can see the spleen and diaphragm here. Again, a pretty large sized effusion with some atelectatic lung, and we can see some static air bronchograms in between here. So consistent with bilateral pleural effusion, there's a single image of heart that was also obtained, subxiphoid view, which shows pretty good function of both the RV and the LV. There's maybe a small size pericardial effusion, but not much in terms of other findings. And so the patient is found to have large bilateral pleural effusions requiring chest tube, which subsequently, after drainage, there's a significant improvement in overall patient's exam and need for respiratory support. And one thing to think about whenever examining any of these pleural effusions is to always try to differentiate if it is a simple or a complex pleural effusion. And often it ends up being just trying to fan your probe so that you can get a more comprehensive view of these right and left lower quadrant images, so that you can see whether there is any stranding or cavitations that are present within the effusion that may help better understanding of that. The next case is a 6-year-old who's admitted to the floor through a referring ED with cough, fever, and decreased PO intake for 4 days. In the ED, is given some antibiotics and a fluid bolus. Several hours after admission, he has an increasing oxygen requirement and a rapid response is called. And then we have some questions to try and be more specific about what we're looking for in this patient. And so if I remember correctly, this is the patient's right side. And we know from our general understanding of ultrasound physics that for the most part, if there is an area that is full of air without any fluid or consolidation, generally we tend to see just these reverberation artifacts and not much more. So all you see are some A lines on this side, which look pretty good. Or I guess that was the left side. Sorry, this is the right side here. On the right side, we can see here is the liver. And then you can see this pretty large area of consolidation with air bronchograms. There are at least 1 to 2 dynamic air bronchograms that we can see, almost no pleural effusion. This would be consistent with a pneumonia. The patient is already on antibiotics. So at this point, it would be supportive management and waiting for resolution of pneumonia. So the findings here were consistent with left-sided pneumonia, right-sided pneumonia with these findings. And there was some interstitial edema in other areas of the lung, but no large areas of consolidation or effusion. Next case is that of a 4-year-old female who was admitted to the PICU with left side pneumonia. She has a stable oxygen requirement on CPAP, but her chest X-ray shows increased opacification of left hemithorax. It was unclear if a chest tube would be indicated. I think these kind of questions are really good to address with ultrasound because it really helps sort out between what is consolidation and what's infusion and whether or not you can approach that infusion safely. So our point of care question here is it safe and is it necessary to place a chest tube in this patient? So here's some images from the left side. This is obtained with a linear probe. We're in that left lower quadrant, but you can start to see the diaphragm. There's like some cardiac pulsations that can be seen underneath. There is a small pleural effusion, and then just a bunch of atelectated, consolidated lung that's present underneath this. And so based on these findings, I would be personally very hesitant to attempt and place a chest tube and would probably consider managing it conservatively, focusing more on airway clearance, antibiotics, and respiratory support while the patient's overall pneumonia gets better. And so this is another one of those applications for lung ultrasound where even though it may not help you directly, it can help prevent patient harm based on just looking at chest X-ray imaging alone. So the review for the case was the radiographic opacification was primarily from the lung consolidation, small to moderate size effusion, remained stable on CPAP. Plan was made to follow clinically and with serial ultrasounds to follow effusion size and character. And so I wanted to wrap up this sort of case with some takeaways for pneumonia. There are a few different signs that help us decide between, that help us diagnose what pneumonia is. Hepatization, which is where the lung starts looking like liver tissue, that's generally a late sign. Subpleural consolidation more than 1 centimeter in size. Dynamic air bronchograms, what we saw in the case prior. Presence of confluent B lines with irregular pleura and then shred signs. So those are the 5 big things that help you differentiate between pneumonia and other pathologies. Of course, it doesn't tell you whether it's viral or bacterial or fungal, but at least you get some clue into the characterization of the disease. The last case that I have for lung ultrasound is this one. You have a 2-year-old patient on VV ECMO for severe ARDS secondary to RSV bronchiolitis. The patient develops sudden onset desaturation and hypotension with bradycardia and a thready pulse. The surgical fellow wants to place a chest tube due to the concern that this could be some degree of hemothorax in the chest, based on a chest x-ray that is whited out and has been whited out for last several days. But you very carefully decide that this needs to be evaluated a little bit closely before we do that, and you obtain a bedside ultrasound. And the specific questions that you have in your mind are, if this patient did have a hemothorax, there would be a pretty large pleural effusion. So is there one? Does this patient have worsening pulmonary hypertension or right-sided strain, given they're on VV ECMO now for several days? Or does this patient have additionally worsening cardiac function? And that explains the hypotension and some of the other findings. So this first image is a little bit different from the images we've seen so far. This is obtained from a subxiphoid view, and it is looking at the right lung, which is right here, with very consolidated, hepatized lung tissue, looks very much like liver. There are a ton of air bronchograms here. There's maybe a small effusion underneath it that you could probably like imagine. Here's the diaphragm. And then here's the right atrium with a echogenicity in the center. That's your venous or your VV cannula. And then along with that, this is supposedly an apical 4-chamber view. Sometimes the images you get are the images you get. They're not all this perfect. But what you can see is that here is the right atrium, which seems to be pretty ballooned out. Don't see much of the right ventricle. And then both LV and LA are pretty decompressed here as well. And then this is the lung ultrasound from the other side. This is the more traditional left upper quadrant view, where you can see the spine sign. You can see pretty dense air bronchograms, collapsed lungs. There's the spleen right there, but obviously no big pleural effusion or fluid collection. And this is an attempt to be between subxiphoid and peristernal long view, but it's a flipped view. So you can see the left ventricle here, which is pretty collapsed, but the contractility seems to be good. If anything, the heart seems to be a little hyperdynamic. And then you can see the RV here that looks pretty ballooned out, which would be concerning for RV failure, increasing right-sided pressures, pulmonary hypertension. So the surgical team wanted to place a chest tube with the concern that there is a large effusion in the chest. Would that have been reasonable? Absolutely not. The patient has ballooning of RV with a small LV consistent with pH crisis. So we actually discussed conversion from VV ECMO to VA ECMO and ended up doing that. But despite doing those, the patient was already doing so poorly that ended up not making it. But in this case, without using POCUS and having understanding of the lung ultrasound, we would not have been able to make that case right away and prevent the harm that could have happened by putting in a chest tube. So those are all the cases I have for lung ultrasound. Eric, if there is time, I have one case that I wanted to show for VTI that I couldn't do the last time when I did the lecture for volume responsiveness. So I can do that, or if people have questions, comments, or want to discuss about the lung cases a bit more, we can do that.
Got it. Why don't we just first see if there's any questions about what you've already talked about, which is great, and then and then do the VTI image if that's okay with you.
Yeah, that sounds good.
Does anyone have any questions or concerns about it? I mean concerns, sorry. Any concerns about lung ultrasound in general or anything like that? Because Videt's have done a great job of covering a more systematic way of approaching it, but was kind of curious what folks' thoughts were and if they're applying it to practice in their own institutions. It tends to be one of the things that people do most when they start out, like our hospitalists are doing mostly lung ultrasound stuff right now. I mean, I think your approach is really interesting, and I like the. Oh, I'm sorry. There's a few people who've opened up their mics. Go ahead.
I had a quick question, Vidit. Thanks so much
Yep.
for doing this, but I clinically at the bedside, I sometimes find that I see absence of lung sliding with a patient that has a clinical reason or a chest X-ray that's consistent with pneumothorax, and I'm trying to dynamically uh, enter the pleural space without injuring the lung parenchyma. So how do you try to position your probe in a way that you won't see lung parenchyma if clinically on chest X-ray or what have you, you see a pneumothorax, but on ultrasound you may see A lines that would be consistent with lung parenchyma. Do you understand my question?
Yeah, yeah. So I think this is a little bit different from how you use dynamic guidance for an effusion. Because with effusion, you can see your pocket of fluid, right? And you can try to enter the largest pocket so you have a margin of safety.
Right.
And what I think, if I'm understanding correctly, what you're trying to ask me is how do you ensure that you can tap the pneumothorax without causing a bronchopleural fistula by injuring the lung, right?
Exactly. Yeah.
Yeah. I think one way to think about it is you can try to mark out the boundary of the pneumothorax. And how would you do that? The way you would approach that is you would use your scanning in two different planes. So you would use sagittal and transverse and try to figure out where is the boundary of this pneumothorax. As you slide from an area that has no sliding to an area where you see lung point, that in my mind would indicate that you have that's the boundary of pneumothorax, at least on one side, and then you can do it for multiple different areas. So you get a sense of how big the pneumothorax is, where it is. But I think in terms of depth, that is something you would not be able to gauge with that. The only thing you would know is how deep can you go before you hit the pleura.
Mm-hmm.
And that's all you can know. So if you have that piece of information, you go in vertically to the skin at 90 degrees and you try to maybe not go in too much further deeper than that
I see.
with
I
that. And I can show you a cool trick at the bedside. So what I do is, you know how with those needles, you have this plastic guard that comes and that covers the needle. What I do is I measure out how deep the pleura is from the skin, and then I cut the guard and put it on the needle. So even if I wanted to, I cannot go in deeper than that.
I see. That makes
And
sense.
so that's a way to like make sure that you've not inadvertently gone in way more than you need to.
I see.
Since we have time, Vidit, I'm not trying to steal your show. Like after you do your VTI, I have a clip from a dynamic pneumo tap that I can show that.
Oh, lovely. Oh,
So,
that'd be great.
but I can do that after you do the other thing, or if
No,
you want me to do it
no.
now. Okay,
Why don't we do it? And then if there's still time, I'll get back to the case.
okay, cool. Uh, just also, Krista, did you have a question?
No,
Oh,
thank
okay,
you.
sure. Do you guys see my PowerPoint up?
Yeah.
Okay. Totally not trying to steal your show here, Vidit.
No, you're good.
So our case here was a 1-month-old who had neonatal sepsis, PPH and pneumonia, was VA cannulated, had a really tumultuous course. Basically, what happened in mid course is that for DSATs, one clinical team decided to. This was at another institution. Decided to ligate the PDA, and then there was a massive hemothorax, and then they evacuated the hemothorax on the left, but then on the right blew a pneumo while they were trying to re-recruit the lung that was down on the left, and then had just a lot of pneumothorax misery. So there's a pigtail along the side here that doesn't really drain anything. There is a thoracostomy tube here along the side. Oh, I'm sorry, can you all see my pointer as well?
Yes.
Oh, okay, good, good. It also doesn't drain anything. And then this is a mediastinal air leak that got into the pleural space, separated the lung from the heart. They could not get this lung back up. This kid was sitting in the 80s on ECMO. And it went so far that the team prior to ours tried to use perfluorocarbon to recruit the lung, was not able to do that either. And so what we did was these views are kind of like, if you guys can see my camera, let me make sure my camera's on. So like literally we put a linear probe on the affected lung, just kind of like in a axial orientation. So the indicator in the upper left hand of the screen is pointing towards the sternum, and then to the right of the indicator is going lateral. So this is the pneumo in the middle. This is the heart. And then so this is kind of like heart point. That's like where the heart is sliding along the pleura. And then this is consolidated lung. And so the pneumo is this window right here. And this is a baby, so this was only about a 2-centimeter window. So the view on the right is where we're then sliding over to target, dropping the needle in right at the edge of the pneumo. And then what we did after that was that, with dynamic insertion, what we prefer to do, instead of doing it short axis, we tried to do it long axis. And we did it with the peripheral. So we had the really long vascular access team IVs, like they're 1 3/4 inch long 22 gauge peripherals. This is not going to be easy with like a 1-inch 22 gauge. But what you do is you guide this this IV over the edge of the de-recruited lung, and drop it into the pneumo, and we watch it at just right as it punctures there, and right as it goes through, you stop, and then with that you just thread the IV so that you have a stable channel, and with the 22 gauge. That'll fit the 0.018-inch micropuncture wire that we use with most of our pediatric CVLs. Then with that you've got access, and then you've got the wire in. Then you probably have to do a dilator switch out where you carefully, over the 018 dilator, put like the chest tube dilator, like an 035 dilator, a dilator that has an 035-inch channel on the inside, the type that goes with, pericardiocentesis drains, pleural drains, and dialysis
Like the
catheters.
micro puncture kits that are there, where you can like take out the sheath and then put in the bigger dilator.
Yes, those are really nice. The dilators that have the inside dilator that comes out. Yep.
Yeah.
That would have been even better. But then with the larger pleural tube dilator, like regular Furman pericardiocentesis kit, you then you put the dilator in place. You can even watch it to make sure that under ultrasound to make sure that you don't puncture too far. But usually, the wire is gonna be somewhat protective about that. You're always going to be really careful in this situation. And then you just switch it out to a pleural drain. And so with an 035 dilator in place. And with that, so the other thing you can use is an introducer sheath, probably. Like you could use like a cordis like a small cordis that would fit your pleural drain dilator, but it would also just be something that, you put the cordis in, and then it's at least enough space that you can put the 035 pleural drain wire through it. But then, so what, this is the pre and this is the post on the right. And so the pleural drain comes in this way. The wire was a little aggressive, went all the way down to the base of the lung. And then but once you're in and you have this oblique track as well, because, the baby's chest wall is so thin, the oblique track, like, makes it easier for it to seal off. So you don't end up like having like a very wide and short track that could leak a lot. So you've got this long tissue track that'll help be protected from that standpoint. And the lung looked awful when we sucked out the air, but this kid actually got off of ECMO in about 2 weeks. So this was a little bit of a chest drain to the extremes, but this was something that this was what we did when we tried to do it under direct guidance, and it worked really, really well for this kid. And if I could just show real quick the point that I think you're making, Vidit, that's super important, is that no one's looking for this to replace X-ray, but it ends up being like a huge adjunct when we need imaging, like right now. Like, when you've got a kid on an oscillator, blows a pneumo, is about to code, and you're seeing SATs plummet, and everyone's got the suspicion in their head, and everyone just wants to know, is this a pneumo or not? But the ultrasound sometimes gives you that information before chest X-ray can get there, or the kid who just got intubated and you see it go through the cords, but maybe it's this kid who's been struggling for a long time and they're still desaturated and they've got such bad pneumonia that the end title's not changing color and everyone's just screaming at you, just get the tube out, just get the tube out. But you put the ultrasound under the diaphragm and you bag real hard. Well, not too hard, sorry. And you see the diaphragm dropping. It's like, no, we're in. We just need to bag the lungs back up. There's things where we don't need to replace X-ray, but we can definitely get to the patient a lot faster. I just have one other case real quick that is this one it? Yeah, this is it. I think helps show how ultrasound complements X-ray, even though we're not trying to use it to replace it. So this is a 9-month-old with a history of a left side CDH. Tons of revisions, status post ECMO, was intubated on oscillator. Had an acute DSAT to 75% on 100% FiO2 and was on nitric. Sorry, those are masks. And so we got an X-ray at the time, and people were like, this kid had their lung pegged up to the pleura ton in multiple occasions from prior chest tubes. So we looked at this, it looks just like the X-ray from the morning, from the day prior. And people are like, I don't know if there's a pneumo there or not if there's a new pneumo there or not. And then, even did a cross table, and it's like, I still can't tell if there's a pneumo there or not. But this kid is like, acutely desaturated. So put the ultrasound on, and we did see what might have been lung point, but the thing is we also saw this, and this is a rib mirroring. And so because when you have a pneumo, ultrasound energy bounces off of the pleural surface and then ricochets back and forth between the skin surface and the pleural surface, but then really doesn't, reflect anything down here. The machine interprets that reflected sound that keeps rebounding back here, back and back and back and back and forth as image signal. And then the machine tries to imagine what is there, but because it's just the tissue that's in here, you see the intercostal space reflected. And so this kid clearly doesn't have two sets of ribs inside one inside the other. It's that the rib is reflected across the pleural line. In a baby, when you have like really cartilaginous ribs and you can see through them. And so we actually called this figure 8 sign in something we wrote, where you get all these 8s. But the idea is that, the lung sliding was hard to see because this kid had so much lung injury in the past, and the pleural was already damaged and tethered in several areas. And so when we saw this, though, it was like, we we had to use it in conjunction with everything else, because right now the only other paper out there on this is a NICU paper that said they saw this in every kid that they had a pneumo in. But I'll tell you, like, sometimes the mirroring signal is a little more subtle, and it's not necessarily a pneumo. Like when you have this perfect mirroring, it's a lot more suspicious. And then we had the X-ray that wasn't telling us anything. We had a surgeon at a bedside. We had a kid who's desaturated to 75%. I told the surgery fellow, the only time we ever see this is a pneumo, and it's right there. And he said, okay. And he stuck it, and he got air, and he put it kind of like an anterior tube, evacuated it. And this is just collapsed lung that re-evacuated. We didn't get, we obviously didn't pull blood or fluid or anything back. And he was like, looks like we're okay. And then CV surgeon walked in and said, hey, I think you have an anterior pneumo on that kid. And he was like, thanks. We just got the tube. So this is just an example of, like, where we were careful, but ultrasound really helped us compose the clinical picture better and try to figure out what was going on. Otherwise, this kid was probably looking at an ECMO run. Yeah, that's all I got.
Both very nice cases, Eric. Thank you.
Cool, thanks. Sorry, that's from like that's from a thoracentesis presentation, but yeah, I appreciate the opportunity to chat about it.
Yeah, great. I think we just have enough time to see if anybody has any other questions. If not, I think we can do the other case some other time.
Oh, okay. The VTI. Do you want to?
Yeah.
I mean, do you want? First, I'll ask. Does anyone have any other questions or comments? Do you want to just go through real quick?
Sure. Here. Let's see. Okay, here. Okay, so this is a 1-year-old who has just had a LADS procedure and an XLAP for a closed loop small bowel obstruction, had a repeat XLAP for small bowel resection, admitted in the PICU with some compensated shock. Here are the vitals for this patient. It's pretty tachycardic to the 180s, even for a 1-year-old. Is febrile also at the time. Here are some like images. These are our classical 3-4 views of the heart with the IVC. So here with this apical view, we can already see that the heart is quite hyperdynamic. There's a small pericardial effusion. Here's a parasternal long axis view, where again you can see that the LV systolic function seems to be just fine. The LVs may be underfilled, it's hyperdynamic here, and very similar corroborating findings here. In the short axis, your IVC is small and collapsible. This patient is intubated, so you have to take that with a little bit of pinch of salt. But those are the basic findings. And then here is this patient's VTI. And right off the bat, you can see that there is just so much variability in between the flow out of the aortic outflow tract. So I took the values from this. Here's the one with the largest velocity, which is around 1.6, 1.7. And the smallest one is around 1.3, and use that to calculate out the aortic flow variability, which is around 26% here. So that would be consistent with being volume responsive. These were taken from the patient's chart when I was doing chart review. These are the attending's impressions. The patient has tachycardia regardless of his fever curve, level of comfort or fluid status, point of care ultrasound, suggested that patient may be underfilled and overall still volume responsive. We'll give him some blood today. Hopefully, we'll give him some oncotic pressure and oxygen delivery. And then this is from day 2. The images are from that day 1, and then after day 2, the overall trend in his heart rate has gradually improved, and it seems like he's responded well to getting some blood in the near syrup and stuff. So overall, that's just like one way that you can use VTI along with all of your other imaging and data points to try and put together who is a patient who may be volume responsive and use it to your advantage.